Yes, no?
Yes, sir.
No clue. Could you please
Okay,
explain?
okay. So this is the tongue. Tongue has anterior 2/3 and posterior 1/3. Here it is. Suppose this is the tongue. Okay. This is the tongue. Anterior 2/3, taste bud, everything is there. Posterior 1/3. The junction is known as foramen of cecum. Foramen of cecum. Okay. Suppose see, this is the tongue. This is the tongue. This is the tongue. This anterior 2/3 and posterior 1/3 is the junction. There is a small foramen called foramen of cecum. What happens from there is a tract will start. A tract will start coming down. So the tract is known as thyroglossal tract. Okay, it will come down like this. A tract will come down, and it descends into the neck. It splits to form the thyroid gland. Okay, clear?
Yes, sir.
Yes, sir.
Yes, sir.
So you should know what is the tongue. Anterior 2/3, posterior 1/3. Junction of the tongue, there is a foramen cecum. From foramen cecum, there is a tract going down. This tract is known as the thyroglossal tract, which will ultimately form the thyroglossal, which will form the thyroid gland. Sometimes what happens is this tract will get, normally this tract should get what it should be there. It should be after life, what it will be there.
Sir.
It should come on. It should
Disappear.
it should disappear. Its function is over. It came down. It forms thyroid gland. It should disappear. If it is persistent, then we have some problems. What is that problem? Heard about this thyroid glossal cyst? Heard about it? Not heard?
Yes, sir.
Heard of it, sir.
Yeah. So this thyroglossal cyst is due to the presence of this thyroglossal tract. Okay. If you just remember these points, you will never forget about that. Okay. That's why I'm emphasizing much on this embryology part. Embryology is clear. Can somebody just summarize? Tell me what is this embryology of thyroid gland?
So yeah, the tongue is divided into the anterior 2/3 and the posterior 1/3 part. In the
Yeah.
middle of the anterior 2/3 and posterior 1/3, we have this foramen of cecum. From the foramen of
Very good.
cecum, we have the thyroglossal tract, which is descending to the neck,
Yeah.
and it splits into tracheal cartilage, forming the thyroid gland.
Yeah.
So thyroglossal cyst is the problem which is arising from the thyroglossal tract being intact.
Yeah. If it is remains, it should get obliterated. After life, the thyroid is here, tongue is here. There should be no connection between. But in some people, there will be that the tract will be persistent. So that tract is known as thyroglossal. The tract, if it forms into cyst, that is known as thyroglossal cyst. Okay.
Yes.
So see here, if the thyroglossal tract persists, it is known as the thyroglossal cyst. Point number 1. And most common it is subhyoid. It pierces the hyoid bone and comes down. So it is subhyoid, the most common. Clinical features, it is a midline swelling. Obviously, it is a midline swelling. It moves with deglutition and protrusion of tongue. Why it moves with protrusion of tongue? Can anybody tell me? It moves with protrusion of tongue. When we move the tongue, the cyst will move. Why?
Because it is attached to the foramen of cecum. Right?
Yeah, it is attached to the foramen of cecum. So whenever the tongue moves, foramen cecum moves. Foramen cecum moves, thyroglossal cyst moves. Clear? And
Yes,
diagnosis is by
Yes, sir, it's
examination,
fine.
ultrasound. Management, you have to know the surgery. The surgery, name of surgery is cyst trunk surgery. Cyst trunk. So here we remove the entire cyst, we remove the tract, and we remove the hyoid bone also, because there may be chance of recurrence. So cyst, tract, and hyoid bone also you have to remove. And long standing, if you leave it like that, there is high chance that the patient will develop papillary thyroid cancer in this. Okay. So first read this question and answer me. Sorry, before this, thyroglossal fistula. Okay. So this is clear about thyroglossal cyst? Yes, no?
Yes, sir.
Clear,
Yes,
sir.
sir.
Yeah. So this is the tongue and this is the thyroglossal cyst here. And you operated it. There is a cyst here. You operated. You made a small incision. Cyst fluid drained. So thyroglossal fistula is an acquired condition. Thyroglossal cyst is a congenital condition, but this is an acquired condition. If you do an improper IND, if you are not removing the entire gland along with the hyoid bone, this will form. You should remove the entire gland. You should remove the entire thyroglossal cyst along with the hyoid bone. Then only this problem will cure. If you do a half job, then there will be a fistula. It will be draining outside. Treatment for this also is cyst trunk surgery. You have to access the entire tract. Okay. So, an 18-year-old lady underwent incision and drainage for thyroglossal cyst. Is the treatment done by the surgeon correct or wrong? First statement. An 18-year-old lady underwent IND for a thyroglossal cyst. It is nonsense. It is wrong. You should not do IND. There is a cyst means you should never do IND here. Okay. You should do what you should do. Which operation you do?
Cyst trunk.
Cyst trunk operation. You have to remove the entire tract. Otherwise, problem will persist. Point number 1. Okay. Later, she noticed discharge from the wound site. Obviously, because you did a half job. Regarding the condition, the false statement is. Read the options and tell me the answer. Whatever you feel the answer is. False statement. I am asking the false statement.
No need to remove hyoid bone.
Sir, answer C.
C. No need to remove hyoid bone.
No need to remove hyoid bone during the thyroglossal.
Very good. Very good. Very good. Thyroglossal fistula is always an acquired condition. Yes, correct. It's always an acquired condition. Management of surgery. Management is cyst trunk surgery. Yes. Ultrasound neck is done to identify the presence of normal thyroid. Yes. Sometimes what happens is the thyroid, this thyroglossal cyst only will develop into thyroid gland. So sometimes it will not develop. So what if you remove the entire thyroglossal tract? What will happen at that time? What will happen?
Thyroid infection, drainage.
Thyroglossal fistula.
Thyroglossal?
No, can the question be repeated again? If we remove thyroglossal tract fully?
If you remove the thyroglossal tract completely, in some patients, normally what I told, thyroglossal tract will develop into the thyroid gland, I told you.
Yes.
In some patients, thyroglossal tract will not develop into thyroid gland. Only it will remain, the thyroglossal tract will be as functioning as thyroid gland also. So if you remove that, what will happen?
Hypothyroidism.
Yeah, the patient will land in hypothyroidism. So it is always better to do an ultrasound before and look for the normal thyroid gland. If normal thyroid gland is there, then you can remove the tract. If normal thyroid gland is not there, then you have to plan accordingly and you have to save the thyroid gland because the patient will be hypothyroid if you remove it. Okay? And no need to remove hyoid bone during thyroglossal fistula excision. That is wrong. You have to remove the hyoid bone. Then only the tract will be excised completely. Lingual thyroid is thyroid gland below the tongue. An ultrasound neck is used to identify the presence of normal thyroid gland. Lingual thyroid is nothing but it is an anatomical variation. The gland is just below the tongue. Then coming clear till now?
Yes, sir.
Sir, previous slide, sir.
Yeah. See, in neck, everything is very small structure. So before you do any surgery, you have to have a clear anatomy of that. You should know where is the normal thyroid gland. Unless you know that, if you operate, you will land into hypothyroidism. So then, retrosternal goiter. What is this? Retrosternal goiter. What is the single point you know about retrosternal goiter? Examination point.
Posterior border.
Lower limit or not?
Lower left is not felt.
Lower limit is not very good. So there are two types of retrosternal goiter. Normally the thyroid gland is like this. It enlarges, it should be like this. But what happens here is there is a sternum here. So this gland will go behind the sternum. Okay, this is a retrosternal goiter. So we will not be able to identify the lower limit. So there are two types here again, primary and secondary. Primary is ectopic thyroid tissue in the mediastinum. Secondary is it starts in the neck and goes below. This is common thing. 90% is like that only. It starts in the neck, it goes below. That is secondary. Primary is ectopic thyroid tissue. Sometimes there will be the thyroglossal tract will go down into the mediastinum. So there will be an ectopic tissue here. Okay, that is one and this is one. Only prevalence is 10%. Primary only 10% prevalence. Secondary 90% prevalence. And look at the blood supply. If it is originating here, it will have blood supply from the mediastinal vessels. If it originates from the neck and it goes down, it will have a blood supply from the thyroid vessels only. Clinical features are the patient will have dyspnea, stridor, swelling because it is compressing the major tubes, the esophagus. There will be dysphagia also, dyspnea also, and stridor. Examination, lower limit of swelling is not palpable. Very, very important point. And Pemberton's sign. If you ask the patient to elevate both the limbs like this, upper limbs like this, because the space is narrow here, the patient will have facial flushing. Okay, facial congestion will be there. So this is the classic sign of retrosternal goiter. This is known as Pemberton's sign. Pemberton's sign. Is it clear?
Yeah, clear, sir.
So answer me this question. I did not tell the management part, but tell me, 50-year-old man diagnosed to have retrosternal goiter and planned for operative management. Regarding the choice of approach, true statement is most common surgical approach is sternotomy. Yes, no. Sternotomy is indicated for malignant retrosternal goiter. Yes, no. Majority of the goiters derive their blood supply from mediastinal vessels. Yes, no. Sternal incision always required. Okay. So, okay, I understand that. I did not discuss these 3 points, A, B, and D. First, you tell me whether C is correct or not.
Incorrect.
Majority of goiters derive their blood supply from mediastinal vessels. Correct or
No,
not?
it's from the thyroid vessels because 90% of them are secondary. Yeah.
Yeah, very good. Others also, is it okay?
Yes, sir.
Yes, sir.
Majority of them are from the neck only. Okay, so most common surgical approach is not sternotomy. I told you 90% are from here, it is going down. So if you open here, it is enough. Okay, clear?
Sir.
So most common surgical approach is, what is that? It is not sternotomy, it is cervical. Cervical approach. Okay, sternal incision is always required. Is it true? Just now I told you, most of the times it is over by cervical incision. No need to give a sternal incision. So this is also wrong. So sternotomy is indicated for malignant retrosternal goiter. This is the right answer. Okay. Is it clear?
Yes, sir.
Please, this is important. This question is asked in last NEET. Okay. So they have a habit of repeating questions from NEET only in FMGE. So just go through it. If you have doubt, I'll just explain it once again. This is a direct question. Understood?
So the surgical approach is always cervical approach. Is that correct?
Not always. Most common.
Most
Common approach is cervical. But if there is an ectopic tissue here, then you have to do a sternotomy, right?
Got it.
Yeah.
Okay.
And what are others? Yeah, tell me. Is it okay? Is this slide clear? Retrosternal goiter is very important. Clear?
The most common approach is cervical approach.
Cervical approach.
Sternotomy is only done in case of malignancy.
Yeah, no, other 3 conditions are there. I'll tell you in the next slide. It is there. Sternotomy is indicated for malignancy. It is indicated for recurrence. Indicated in primary. That is, if the ectopic tissue, if the blood vessels are in the mediastinum, ectopic tissue, I told you, primary is retrosternal goiter. Then also you have to do a sternotomy. If it is secondary, that means if it is coming from the neck into the chest, no need. If it is primary, if it is here only, then you have to do it because mediastinal vessels are here. You can't approach the vessels from here, right? So you have to open the sternum and you have to ligate it. Okay?
Okay,
Yeah,
so primary, malignancy, and ectopic.
Yeah. MRP, malignancy, recurrence, and primary. Okay? These are the indications of sternotomy. Otherwise, no need of sternotomy. The approach is cervical. Okay? Yes?
Okay.
Yeah. Primary, only how many percent? Primary?
10%.
10%.
10%.
10%. And what is the blood supply of primary?
Mediastinum.
Mediastinum.
Mediastinal vessels. Very good.